All right, everyone. Thank you for joining us for this webinar entitled, When Does the Risk of Not Testing Outweigh the Risk of COVID-19? And that title, of course, is in the context of urine drug test monitoring, drug testing in general with regards to patients prescribed opioid medications or in medication-assisted treatment or other treatment facilities. I'm going to be going through a brief webinar today, about half an hour. We're going to share some of the most recent information, some of the concerning trends, and try to give you as much information as possible to help you as healthcare providers, as clinicians, make wise choices as we deal with these unprecedented times. So to begin, what is at stake? We know that right now across the world and in the United States, certain categories of people are at enhanced risk for contracting and having complications of COVID-19. This webinar is really going to talk about the intersection of that with the U.S. opioid epidemic. So patients with increased risk of COVID-19 complications do include those who have a history of drug abuse, especially methamphetamine abuse disorder, opioid use disorder, those who have smoked tobacco and marijuana use histories, those with histories of vaping, those who have depressed internal organ function and complications from long-term drug use. But we also know that those who are now isolated or are unemployed all of a sudden are at an increased risk for drug misuse and abuse and alcohol abuse. And that can also increase the risk of mortality for reasons that are not directly related to contracting COVID-19. And ultimately, clinicians are responsible for deciding what's best for their patients. What we're trying to do here is present as much information as possible as it's coming out to help sound the alarm about, I think, a potential inflection point where the COVID-19 pandemic in the United States, at least, is now potentially less dangerous than the continuing U.S. opioid epidemic. Some of the most alarming data is coming out of the harm reduction programs, which have first response networks for reporting opioid use overdose. We're seeing those increase now. So, I started one of my last webinars with this slide. Again, I think it's very pertinent. This may look familiar. This is actually not a map of U.S. COVID-19 case reports. This is a map of U.S. prescription density for Suboxone. So this is more or less a map of where the U.S. opioid epidemic is taking place. Notice that it does tend to cluster around certain urban centers, but are also some rural areas. And there is overlap where COVID-19 is increasing, especially in areas like Chicago, Detroit, the tri-state area, parts of Florida. And so, what we see is that we have a number of people who are at risk, and there's an intersection between that and the COVID-19 cases that are spreading. So this is data from March 26th from the Johns Hopkins Reporting Center. And I'm going to switch and show you now data from from today, April 15th. So qualitatively, not a huge change. We don't see new hotspots showing up over the past 3 weeks. Those areas that are having difficulty, New Orleans, New York City, in the tri-state area, Detroit, and a few others are continuing to be impacted, but we are starting to see that curve flatten, so to speak, and some of these case reports trending towards a flat line or even declining in certain areas. So I'm not going to say that we're out of the woods yet, but we need to start to take a look at the serious implications for what the past 5 weeks and the next 2 to 10 will have on those most vulnerable who have been prescribed opioids in the past, are currently using them with limited monitoring now, and those who are engaged in medication-assisted treatment or substance abuse treatment programs. So this is a relatively recent correlation from the end of 2016, U.S. county-level poverty and drug overdose death rates, combining U.S. Census Bureau data and projections and poverty estimates, and the CDC's small area estimates for drug mortality at the county level. So what you see is a bicolor plot by county. Dark red indicates places where overdose deaths are at the highest. The bluish turquoise color indicates where U.S. poverty is at its highest, and the dark purple indicates the intersection of those. And so you see large swaths of the Mountain West in southern Colorado, in Arizona, Northern California, New Mexico, parts of Oklahoma, Missouri, throughout Appalachia, particularly Kentucky, West Virginia, southern Ohio, northern Tennessee, parts of rural Maine. These are areas where we're seeing high rates of poverty and overdose deaths. And again, the correlation here has been studied at length, and there appear to be a number of mechanisms that we'll discuss briefly as to why it is that lower income or unemployment increases the risk of drug overdose and overdose deaths. Concerning is the massive spike in U.S. jobless claims. And so you guys can see where we're going with this is that what's shaping up here is a very concerning trend of massive increases in U.S. unemployment and potentially a spike in poverty that may come along with that. So there was a 3,000% jump in U.S. jobless claims, going from a weekly average for the past 45 years of about 300,000 jobless claims per week, lower than that recently. And now we're averaging over the past 3 weeks over 5 million. So there were 3.3 million from the last week of March to the first week of April, 6.6 million, followed by 6.3 million. And the projected numbers for this week will likely be over 5 million. So we're rapidly heading towards having over 20 million Americans having filed recent jobless claims in the past month. This is just an article highlighting that. Currently, we're at 17 million Americans having filed new claims for jobless benefits. These include employees that have been laid off completely, those who have been furloughed until further notice, or those who have suffered temporary wage reductions. And this is a large number of the of people engaged in the American workforce, not just those in service industry sectors that may have been directly impacted by social distancing and so-called government shutdowns in certain areas, but also employees at large companies to small businesses that have not been able to maintain their wages either through hour reductions, furloughs, or being laid off. Here again is that 45-year average data, just to highlight what's going on. So again, the data here are reflected our weekly reports since the 1970s. The recessions are highlighted in dark gray bars. The forecasts coming out from Goldman Sachs, the Federal Reserve, suggests that we're headed into another major recession. I don't think anyone's surprised by that at this point. Recessions take years to recover from potentially. And so we may see the long-lasting impacts of this on how it affects the U.S. opioid epidemic and U.S. drug use patterns persist for years to come. So this paper from 2017 highlights the varied mechanisms of how it is that economic recession and unemployment increase illegal drug use. They highlight 5 major mechanisms after an extensive review of the primary literature over the past 15 years. So one is the income mechanism by which people see a reduction in their wages, and that leads to less spending on illegal drugs, or increases their use of cheaper drugs, which potentially puts them at risk. So some of these things have feedback mechanisms that are complicated. Job chances mechanism. Recessions lead to job loss, and people may decrease their drug use temporarily to increase their chance of holding on or getting a job. So these are some of the potential positive impacts which have to be taken into account. Again, this serious study here looks at the different ways in which these mechanisms both enhance or decrease the likelihood of illegal drug use. The psychological stress mechanism is a countercyclical mechanism in which economic recession leads to job loss and fear of job loss, which leads to psychological distress or anxiety, and people may turn to illegal drugs or prescription drugs for that matter in order to cope. Not to mention the use of alcohol, which is not studied explicitly in this report, but we will touch on that later. The non-working time mechanism. So, and this is definitely something that we're seeing a direct impact right now with people social distancing, people working from home, people having to engage in childcare at home, not being able to get out, People are spending much more time at home, oftentimes with large amounts of alcohol or access to drugs that they have stored up. And that increased amount of time and reduced working hours leads to more time spent using drugs. And finally, the social exclusion mechanism. And again, that's probably one of the most highly relevant aspects of how all of this is playing out. Even if people have not fully lost their jobs or become unemployed, the social distancing and exclusion mechanism can lead to an increase of illegal drug use. And specifically, the study highlights a number of other studies in this review suggesting that during periods of economic recession leading to job loss, persons' loss of social status and lead to social exclusion, and that may be coped with by using illegal drugs. So, in a recent article in NPR quoting several experts noting that opioid addiction is a disease of isolation and that the pandemic puts recovery at risk. And I'm going to read a few, I think, pertinent quotes here. So now we're isolating all these people and expecting them to pick up the phone, get online, that sort of thing. It may not work out as well. And when he's saying may not work out as well, he's suggesting work out as well as patients coming into group settings, which they are relying upon for their treatment, coming in and being monitored, oftentimes submitting a urine drug test or having a physical examination by the doctor or healthcare specialist. Again, we need to be aware that there has to be caution about giving significant take-home medication to patients who are clinically unstable or actively still using other drugs, because that could lead to more problems. And that comes from Mark Perino, the president of the American Association for the Treatment of Opioid Dependence. So in our last webinar, we touched on the loosening of regulations at the federal level, but also the recommendations by a number of medical associations, suggesting that patients be prescribed not just 30-day limits, but up to 90 days of opioid medications, Schedule 2 through 4 substances, in order to minimize their chances of contracting COVID-19 by having to go back into the clinic for a visit. In many cases, that is likely the right choice. We're not saying that's necessarily bad here, but what we're saying is that there are new risks associated with that, or perhaps simply the old risks that we were aware of, heightened now by the fact that people are isolating, people are no longer able to come into positive group settings, and they may be more prone to using or abusing their now larger amounts of opioids that they've been prescribed. For active drug users, being alone when taking high level of opioids increases the risk of fatal overdose. And we'll touch on that later, specifically concerns about effective Narcan use and whether or not people who are engaged in social distancing but still engaged in drug use may be at increased risk of fatal overdose. And again, some inpatient and outpatient programs are not accepting or admitting new patients because they aren't prepared yet to operate under the physical distancing rules. You know, this is one of the, I think, the most challenging aspects of all of this is that what's done is done now. Over the past 2 to 4 weeks, clinics that have been scrambling to figure out how to maintain during this unprecedented period of social distancing and regulation, having clinics closed down, trying to move to telemedicine on a moment's notice. There were a number of new patients who needed help who likely did not get help because clinics were not accepting new patients or because they were unaware of what to do now that clinics are closed. We have an epidemic in the midst of a pandemic. This is a recent article from the Annals of Internal Medicine. You know, again, although the pandemic threatens everyone, it is a particularly grave risk to millions of Americans with opioid use disorder, who, already vulnerable and marginalized, are heavily dependent on face-to-face healthcare delivery. Rapid and coordinated action on the part of clinicians and policymakers is required if these threats are to be mitigated. So this is a call to action for appropriate use of telemedicine, managing the risk for patients who are at a heightened chance of complications or contracting the disorder. It also states that efforts are also desperately needed to reduce face-to-face clinical encounters to treat opioid use disorder during the pandemic. Some disruptions in the care of patients with opioid use disorder are inevitable during the weeks and months to come. However, extraordinary planning and support can limit excessive disruption and its dire consequences. These efforts will require new partnerships, unprecedented use of technology, and the dismantling of antiquated regulations. We've seen the dismantling of regulations. hopefully we're seeing new partnerships, and hopefully this webinar can help to encourage you to engage in those types of new partnerships, whether it be with telehealth providers, with organizations such as ourselves who are trying to increase the use of new technology such as DNA authentication for monitoring patients. But this is a time to move away from the status quo rapidly, and to take bold action to figure out how it is to minimize this new set of risks that comes from the intersection of COVID-19 and the opioid epidemic. I'd be remiss to not mention alcohol abuse. So this is a recent article from The Lancet citing how it is that alcohol use and misuse during the COVID-19 pandemic could be a potential health crisis. You're hearing people say much the same thing about opioid use and other drug use disorders. I think one of the most pertinent quotes from all of this is the last sentence where they suggest that as well as the important public health advice, governments should give public health warnings about excessive alcohol consumption during isolation to protect vulnerable individuals. So, I mean, I think that may be a little bit too mild, actually. You know, government advice on limiting alcohol use is all fine and good, but I think we have to recognize the fact that alcohol sales are up 22% year over year since the end of March. You know, there's actually reports of alcohol delivery sales being up over 1,500%, over 1,000% increase in alcohol delivery sales. There's a new industry of delivering alcohol to your door that's taking off now. People, again, are isolated. They're bored. They're anxious. They're nervous. They may have been recently laid off or unemployed or furloughed. Alcohol is the drug of choice for many in the United States and other parts of the world. So that's definitely something to be concerned about. You know, we see a number of officials really starting to sound the alarm about the intersection of COVID-19 and fatal overdose deaths. This is a quote from, or set of quotes from the U.S. Attorney for the Western District of New York. I think we need to consider the role that social isolation coupled with nonstop reporting of the pandemic may have on the feelings of desperation and hopelessness among those struggling with substance abuse. Amidst the current crisis, we need to remember that substance abuse existed long before COVID-19 and will likely remain long after we have wiped out the virus. I think that's incredibly true, and we'll show some data speaking to that in just a bit here. You know, I mentioned this in the first couple of slides. So, you know, this is a quote from the director for Next Harm Reduction. Their Next Naloxone project is advocating for putting naloxone in the hands of anyone who needs it. You know, her quote is that they're just streaming in, and that was with regards to Next Harm Reduction's online reporting system, seeing a 300% increase in March for overdose reports for opioid use. You know, what's it going to look like in April year over year? Likely going to go up again. So we're starting to see a lot of these people on the front lines and dealing with opioid overdose reports, sounding the alarm that overdoses are up. The NIDA director has been quoted in the same article, citing her incredible concerns. You know, she's saying, if you're a person addicted to an opioid and you cannot find drugs, you get desperate and you do very risky behaviors, Dr. Volka said. I mean, that is likely to be one of the consequences of people that need the drug, so that the body's experience it as a need. So if they don't get it, they'll actually consume something that would otherwise they wouldn't have if they had choices. So, you know, again, this goes back to the different mechanisms that lead to increased drug misuse and overdose deaths. So patients may have have lower income, but they still have the same need. They may turn to cheaper street drugs. They may turn to the use of household substances in order to get high, use of inhaled substances. And we may see overdose deaths that are occurring now due to people doing very foolish things in order to try to manage their opioid use disorder. COVID-19, you know, again, I mentioned this at the beginning of the webinar and in our previous one. NIDA has cited a number of risk factors associated with patients who have COVID-19, or patients who have drug abuse disorders. Because COVID-19 attacks the lungs of persons using the following substances are at particular risk. Smokers of methamphetamine, smokers of tobacco or marijuana, people who vape. Additionally, those with opioid use disorder and methamphetamine use disorder tend to have pulmonary and respiratory health issues related to their drug use. So that's kind of a double whammy. So again, this is all part of that intersection of how to weigh the risk. Patients who are using methamphetamine and opioids, especially who have engaged in misuse of opioids in combination with methamphetamine, which is very common in certain parts of the United States of America, are at increased risk of complications from COVID-19. So how best to deal with that? How to continue to monitor and manage those patients while minimizing their chance of contracting COVID-19. And that's the ultimate question of the title of this. When does the risk of COVID-19 become less than the risk of overdose death? People are concerned about Narcan use no longer being effective. Again, this is a quote from the coroner for Franklin County, Ohio, Dr. Ortiz. If you think about it, we advise people who are using drugs to use with someone else who is carrying Narcan. That's the official federal and state level guidelines for harm reduction using naloxone injections or naloxone nasal sprays. Well, they can't do that now if they want to be safe against COVID-19. So they're using in solitary, and there's no one there to administer Narcan. Again, this is something that may be revealed after the fact when overdose deaths that are currently going underreported due to isolation start to turn up in the weeks and months ahead. It's a scary thought. The data projections right now suggest that it's been 5 days since peak resource use in the U.S., and that's use of ventilators, ICU beds. It looks like we've started to turn the corner in terms of hospital admissions and severe cases. I'm not going to say we're out of the woods yet. We still need to follow recommendations of public health officials with regards to social distancing and minimizing the chance of spreading this disease so that we don't see a second wave or new hotspots show up. But we're starting to see maybe the edge of the woods. We're not out of it yet, but we're starting to see the light. A similar trend in U.S. deaths. It's been 2 days since projected peak U.S. deaths based upon total severe cases. Deaths lag, so the actual numbers will be coming in over the next week, and we may see the actual peak show up shortly here. We certainly hope so. And all of this has led to a revised projection with the median deaths being estimated at 68,841 COVID-19 deaths projected by August 4th, 2020, when the curve will supposedly be flattened. So I'll just go ahead and point out right now that is, about 1,500 deaths lower than the official reported drug overdose deaths in 2017. It's a couple hundred higher than the total number of drug overdose deaths in 2018. And these trends with massive increases in synthetic narcotic overdoses other than methadone, that's fentanyl overdose, that's fentanyl and counterfeit pills, fentanyl that's been laced with or that's been laced into low quality heroin or cocaine. That's what's been driving opioid overdose deaths and driving overdose deaths in general. With decreased effectiveness of Narcan because of social distancing and not being used when it could have been. Patients having increased opioid supplies, patients unable to go to their group support meetings, no longer getting the monitoring that they would normally get in inpatient care or intensive outpatient care. I think it's very reasonable to suspect that we're going to see an increase in fentanyl and other illicit opioid overdose deaths in the coming year. So we're here to talk briefly at the end of this webinar about distance solutions. You've heard nonstop from just about every news outlet, every source of healthcare information that integrating telemedicine is key. We also want to add to that at-home drug testing is possible with the use of technology safely. Drive-through drug testing is also something that can be done safely. We have a number of clinics working with us that have adopted measures to do drive-through drug testing safely. And then again, because there are certain individuals who are at an incredibly high risk of opioid overdose deaths, but also have a high risk of complications from COVID-19, Safe clinic visits need to potentially be reserved for those individuals under certain situations. That means that as many patients who are at lower risk that can do at-home drug testing or engage in drive-through drug testing need to take place, so that those individuals at the absolute highest risk that need to be seen by a doctor in face-to-face can come to a clinic with minimal amount of other individuals present, so that appropriate safety precautions can be taken to allow safe drug testing and safe face-to-face visit and examination by their doctor. Again, a link to a Lancet article. I think a pertinent quote here from the Director of Health and Technology at the University of Rochester Medical Center in New York. The majority of patient consultations in the United States are now happening virtually. I think that's a good thing overall. But again, when it comes to monitoring somebody who is using or has a history of drug use or misuse, the need to have drug testing to make sure that they're being compliant on some level is still there. How to do that via telemedicine, there's a number of options, and we'll touch on that briefly. We're racing to implement virtual healthcare technology as quickly as we can. The scale and pace of change is unprecedented. People are being encouraged to experiment and try things and see what works and what sticks for their patients. I encourage you to do the same. Take this information and use it to judge what might be appropriate for your patients. Try to stratify the risk among different patients and figure out which solutions will work for certain patients and what the risk may be at in your area. This is some of the data that we've been gathering. About 3.5% of patients will attempt to substitute their urine during a 2-year period. This is part of the reason why, urine drug testing at a distance, people have a lot of skepticism about it, is that the tendency for a significant number of patients to tamper or falsify their urine could occur. We also see that when patients are monitored, we can actually identify 5 different categories of tampering and falsification using our technology. So urine substitution with DNA authentication, that's something that can allow drug testing at a distance. We can also detect synthetic urine use and substitution of that. We can detect pill scraping or the addition of medication directly to the urine via parent-directed metabolite anomalies. And of course, we can detect dilution and chemical adulteration. So these are all ways in which urine specimens that are collected remotely and dropped off at a clinic or mailed back in through some of our at-home services, can be monitored, and we can still detect a number of adulteration or tampering and falsification events to try to keep patients honest and compliant during these critical times. This, again, I think it's important to recognize that no one approach is going to work for all patients or for all clinics. We're already seeing clinics adopt, in some cases, all 3 of these different options that we've tried to work to develop. So again, at-home testing for patients for which COVID-19 is likely at a higher risk than the risk of them engaging in drug misuse or having a fatal overdose. At-home monitoring with telemedicine may make sense. Telemedicine monitoring with witness oral fluid collection is certainly something that a number of healthcare providers have started to put into use, but also urine drug test monitoring with DNA authentication that allows patients to privately collect urine and mail back into the clinic can still provide a comprehensive drug test that helps doctors get the most information possible about patient compliance. Drive-through drug testing in certain areas where the travel restrictions are light enough to allow patients to travel to their clinic and stay in their car. They can interact with a processor who's using all the appropriate personal protective equipment. They can drive up after being contacted via cell phone. They can submit an oral fluid swab sample that's safely collected, and that specimen is accessioned and then shipped directly to the laboratory at that point. Again, we can detect 68 substances via oral fluid and get a very comprehensive drug test result from that without having the patient leave the safety of their car, potentially spreading or communicating illness to members of the clinic or to other patients, but also minimizing their contact and their risk of contracting. And lastly, if at-home and drive-through testing options, telemedicine visits are being utilized effectively, the clinic can be reserved for working with the most vulnerable patients, those who are at the highest risk of opioid overdose deaths, or that need critical care and direct observation, a physical checkup and examination by their doctor. Again, many clinics are using this approach right now, not just those that are engaged in monitoring patient compliance when it comes to prescribing medications. Even primary care doctors are still accepting patients for on-site visits, but they're finding ways to separate those with respiratory symptoms from those who are coming in for other reasons. And they're using those on-site clinics for the most critical checkups that need to happen on-site. And again, this seems to be one of the best ways to act responsibly and keep people safe. Limit that on-site clinic for those patients that need it the most, those who are at the highest risk of opioid overdose deaths. Keep that clinic safe and clean with as few people as possible in there, and allow those patients that can submit drive-through specimens or engage in telemedicine from home, go ahead and do that. So wrapping things up, and I'll mention this briefly because I'm more concerned about getting you the information than about these specific products that we offer. ToxDirect is a product that we offer that allows urine or oral fluid specimens to be mailed directly to patient, to be mailed from the patient's home directly back to the laboratory. Oral fluid drive-through programs with specimen processors. This is something that we have a number of clinics that have been set up and using. And then clinic processing using traditional means, but with heightened social distancing and sanitizing procedures. We've instituted a number of additional sanitary procedures for our specimen processors, including the additional use of PPE, sanitizing all surfaces that may come in contact with patients' hands or with respiratory particles. And we're putting this into great use both within our laboratory and also at various clinics in which they're still seeing a limited number of patients on site. So in closing, when is the COVID-19 less of a risk than overdose? I don't have the answer for that in every circumstance, and I'm not going to pretend like I do. But what I will point out are some of the trends that I'm seeing right now. Nationally, projected COVID-19 deaths are at similar levels to the 2017-2018 overdose deaths. We're at an inflection point where opioid overdose deaths could easily overtake COVID-19 as being the leading killer of Americans in 2019. I'm sorry, in 2020. We're seeing unprecedented economic factors of recession and unemployment. They're unfolding right now, and those consequences, will manifest themselves in the later months of 2020 and beyond. We know that there is a correlation between increased unemployment, but also increased social isolation and drug misuse, alcohol misuse, and overdose death. Most extreme social distancing is predicted to continue for 2 to 10 more weeks, depending upon the area. God forbid if we see a second wave of infection starting or new hotspots picking up, that could last even longer. Again, those social distancing and isolation factors are likely to increase drug misuse and overdose death. The regional intensity of COVID-19 infections shouldn't pass the risk assessment of healthcare providers. If you're in an area that's less impacted, it's not a call to completely give up social distancing or not take appropriate precautions. But again, start to think about drive-through testing, doing some monitoring, doing safe clinic testing for patients who are at risk, as these things all might help to mitigate what could be the increased risk of fatal opioid overdose deaths or overdose deaths from other substances. So with that, I'll go ahead and end. And if there's any questions, Kyle, if you want to take any questions through the chat and fill them to me, I'll go ahead and start to answer some of those, okay? Okay. All right. So let me get my chat window up over here. Okay, so the first question is, how does at-home testing work? So there are two ways to effectively do at-home testing. Um, Both of them involve the use of a telemedicine visit and check-in to monitor the patient's wherewithal. If you have pulse oximetry and have that equipment on site with the patient, you can use that to monitor patient vital signs. But even if you just have something as basic as a telemedicine call via smartphone or just a voice or audio call, you can contact the patient and you can have them submit a ToxDirect specimen. And a ToxDirect specimen for initial patients involves a buccal swab that ideally will be collected via face-to-face video conferencing. Patient DNA is collected safely and non-invasively. And then that DNA is used to match to the residual DNA that's in patient urine to make sure that the urine is authentically theirs and hasn't been tampered or adulterated with. So the patient can, from the privacy of their own bathroom after the telemedicine visit is over or before they engage in it, they can submit a urine specimen. We provide so-called Vacutainer cups and tubes. So patients can submit a urine specimen as they would at a clinic. Simply use the Vacutainer tube without any risk of contacting the actual urine directly. Fill up 1 or 2 tubes with urine. And then use the provided return labels, either for U.S. Postal Service or the designated carrier in that area. Certain clinics and providers also are using the option to do drop-off or collection with specimen processors. So that's something that, depending upon your area and what's feasible, we can set up a number of different ways in which those specimens can be returned to the clinic. Again, it hinges around the use of DNA authentication to make sure that the specimen actually matches that patient's DNA. And the other alternative is using oral fluid via a witness face-to-face video conference call. Sometimes that's easier for new patients if you're not already engaged in our ToxDirect program, and we can help you decide which one will work best for you. Okay. All right. So the next question, have surveyed patients and asked their concern over social distancing adherence and need desire to acquire illicit substances. In response to naloxone partner use, do they consider one more important over the other? So I have not directly reviewed and covered surveys. I think that there's a lack of data right now because NIDA and SAMHSA, which do a lot of this reporting and monitoring, are having trouble getting out into the field and actually collecting information on what people are expressing. And so I've turned to certain harm reduction type organizations such as Next, and they are expressing that there is concern that if people are using opioids by themselves or without direct access to a friend or family member who has their naloxone, that they may not be able to be revived if there is a overdose death. So again, I don't think we exactly know the question about how drug users are expressing their concerns, and I think that's one of the big problems is that the ability to communicate with people who are at greatest risk, people who are known to have opioid use disorders, we're not able to hear from them through the normal channels because they're not coming into visits as often. So, yep. Okay. All right. Well, with that, we'll go ahead and wrap things up here. Thank you very much for your attendance. Kyle Walker has got your emails, and we'll be sending out. I believe that we're going to send out slides and a follow-up link to this if you need any more information. And if you have any direct questions as a follow-up, you can respond to that email link and get in touch with me, and we'll do our best to help you out with any additional information. Again, we're going to be continuing this webinar series as things progress, as we get more information, and we'll try to answer more questions as more information comes available. All right, thank you very much.